Hello, everybody, and welcome to an interview that we were doing with Dr. Jessica Eccles for our 4th annual Neuro Pride Festival. For those of you who aren't aware, this is Ireland's only cross neurodivergency festival celebrating Neuro Pride, culminating in our Neuro Pride Day, which is on the 8th of August. And we'll have many different events. It's all online, and you can check them out for the next coming days. So the idea today is that we're going to record this interview, and then we'll watch it. And after you've watched this interview, we'll then have a discussion later. On behalf of Neuro Pride, I would just like to say how appreciative we are of Dr. Eccles taking the time to discuss their research with us, because this is such vital research for the neurodivergent community, and it is really it can have a real life impact on the lived experience of neurodivergent people, because of the huge links between neurodivergency and joint hypermobility and conditions such as EDS, Ehlers-Danlos syndrome. So yes, without further ado, I may introduce MAQQI, who is here on behalf of Neuro Pride to conduct the interview. MAQQI is a Neuro Pride contributor, but they also do a lot of training. They've been an activist and advocate in this area for, I think, going on 30 years at this stage. They are very interested in research, and they're very interested in a lot of the research that Dr. Jessica Eccles has produced and in this area themselves. And we're really delighted that they have agreed to facilitate this interview because, as I said, they are very knowledgeable in this area. And so I'll do a brief introduction to you, if that's okay, Dr. Eccles. You're a reader in brain body medicine in Brighton and Sussex Medical School. I'm really delighted because every time I tried to say that before, I kept on saying Essex. So, you know. Yes, and your areas of expertise are brain-body interactions and joint hypermobility and neurodivergency, obviously. But I was wondering if you would be able to give us a bit more of a fuller bio of yourself and kind of discuss that with us.
Of course. So I'm Jessica Eccles. I work at Brighton and Sussex Medical School, and I have a really interesting job in that I spend 3 days a week doing research, and pretty much all of my research is related to brain-body interactions, and I'm sure we'll talk more about that, but specifically how differences in connective tissue relate to neuropsychiatric phenomenon. And so I do that 3 days a week, and that's really satisfying and interesting. And then 2 days a week, I work in a really lovely neurodevelopmental service. So this is a transdiagnostic service where we assess adults in Sussex for autism, ADHD, and also, which is quite rare, Tourette syndrome. Not that Tourette syndrome is rare, but it's rare that services do that sort of work together. And so sometimes when I'm doing an assessment, we diagnose all three all at once, which is quite unusual. So I've been working in the hypermobility field since 2009, and I first started working in the neurodevelopmental service during my psychiatric training back in 2013.
Fantastic. Thank you so much. So now I'm going to hand over to MAQQI to talk to you in more depth about your research, why you got into this, why this area is of particular interest. And yeah, I will jump back in on the end to say thank you, and yeah, talk to you then.
Brilliant. Thank you.
Unmute, always a good idea. To pick up on what Gillian was saying just there, I mean, I've heard the story, but how did you, what got you into this? Because I think that's actually a good story for people to hear, first of all.
Yeah, no, in some ways, I mean, it's an interesting story. So when I was a medical student, I was a medical student for my clinical years in Oxford. I was doing a rotation in orthopedics and musculoskeletal medicine. And as a person, but particularly as a young person, I had a lot of orthopedic problems. I had arthritis in my hip as a consequence of a condition called developmental dysplasia of the hips, also known as clicky hips or congenital dislocation of the hip. Anyway, so I had quite a limp. I was in a lot of pain. And when I was at medical school, a orthopedic physician, which is an unusual thing, they're normally surgeons. This was a doctor who specialized in rehabilitation medicine, said to me, after a ward round, you have sway back knees. Do you realize you're hypermobile? And I hadn't really heard or thought much about it before that point. Obviously, I was quite concerned about the levels of pain that I was experiencing. And I went to see this doctor in clinic, and he sent me, so at medical school, you can do little optional modules. So instead of doing an optional module, I went to a intensive daily pain rehabilitation program where I learned about you know, kind of relaxation, pacing, all of that sort of thing. So that was a sort of an unusual experience to be a patient and to be a medical student. And I'm struck now by how kind of relevant that is later on. So after medical school, I came to Brighton and I did my general, what we call foundation training. So, you know, going around the hospital, doing all sorts of different things. And I decided I wanted to pursue an academic career in psychiatry. And I was quite interested in the philosophy of psychiatry. I'd done that at medical school. And I thought that the brain and, you know, how people were completely fascinating. So that was why I wanted to do academic psychiatry. And I came after a couple of hiccups to Brighton and Sussex Medical School, which at that point was a very new medical school. It had only been in existence. So it's 20 years of BSMS this year, 2024. So it was only 2 years old. And when I came to Brighton and Sussex Medical, not 2 years old, it only had a graduating year for 2 years. When I came to BSMS, I met the foundation professor of psychiatry, Professor Hugo Critchley, who is a wonderful man. And his interest is something called autonomic neuroscience, which is sort of the relationship between body physiology and emotion and thinking. He is you know, world renowned for his work on interoception, the sensation, you know, the internal sensation of what's happening in your body. And by training, he is a brain imager. And when he had been doing his brain imaging work before coming to BSMS, he had done it at Queen Square in London, which happens to be opposite the National Hospital for Neurology and Neurosurgery, where Professor Chris Mathias had developed an interest in postural tachycardia syndrome. And so they've been doing a brain imaging project there, postural tachycardia syndromes, where you get dizzy, lightheaded, palpitations when you stand up. And they'd noticed that a lot of the postural tachycardia syndrome patients were hypermobile. And at that point, there was a fair amount of literature, particularly coming from Spain, suggesting there was a link between hypermobility and anxiety. So Hugo said to me when I arrived to start my combined clinical academic training in psychiatry, he said, "Have you heard of hypermobility?" And I said, "Yes. In fact, I think I am hypermobile." And he said, "Well, what I want you to do is to, as your first project, is it's only the first year of the brain imaging centre, which we have at the medical school. He said, I want you to see if there is a difference in the brain structure of hypermobile people compared to non-hypermobile people." So I set about learning how to use this brain imaging technique, and we put into the analysis all of the people who have been scanned as healthy controls in the previous year or so into the package, and worked out which bits of the brain were structurally different in hypermobile people compared to non-hypermobile. And for a new researcher, this was actually very exciting, because what popped up We did this in 72 people. What popped up was there was a difference in something called the amygdala on both sides of the brain. Now, the amygdala is what people think of as kind of like the reptile brain. It's sort of related to fear and emotion processing. So we thought, wow, this is maybe part of the story about the link with anxiety. But Hugo had also, when he was a psychiatric trainee, he had been involved in a Tourette's clinic, and he was interested in autism and ADHD, which was actually relatively unusual back in 2009. And we noticed, or he noticed, that some of the brain imaging findings that we had, the structural brain imaging findings, was similar to findings that had been seen in autism and ADHD. So right then, at the beginning, at that point, there were a couple of case
even at this
studies.
point, we're talking almost perfect storm.
Yes, of everything
Circumstances
colliding.
just falling into place.
Yeah.
Accidentally.
Yeah,
almost.
no. Exactly. So right from that very sort of initial analysis, we were thinking, well, there's something going on here with anxiety, and there's also something possibly going on with autism and ADHD and hypermobility. So that was back kind of 2009, 2010. We subsequently published that paper in the British Journal of Psychiatry in 2012. But at that point, no one had really done any thorough studies about the relationship between hypermobility and neurodivergence. Of course, we weren't thinking of it as neurodivergence then. Unfortunately, we were talking about neurodevelopmental disorders, and our language was quite deficit based, which I apologize for, but that was how it was.
The world.
But the interesting thing is, and I suppose I should probably say to people, is kind of what is joint hypermobility, because it's not necessarily the kind of most intuitive concept. So some people are aware, you know, that they can do the splits, or that they are what we colloquially call double jointed. But joint hypermobility is where you have joints that are flexible and extend more than the typical. And so people who are hypermobile can do things like this: bend their little finger back 90 degrees. They can put their thumb back on their wrist. They can bend their elbows backwards. They can bend their knees backwards. Often they can put their hands flat on the floor without touching their knees. But it's a bit of a red herring. Well, it's not a red herring in that it is responsible for sort of pain, joints coming out of socket or nearly coming out of socket, you know, difficulties with things like, you know, ankle sprains. But joint hypermobility is just a marker of an underlying difference in how the body is built. And that difference, it's kind of like the fabric of the body, the connective tissue. It's pretty much everywhere. And so that means people with hypermobility, with this difference in their connective tissue, they often have easy bruising, soft, stretchy skin, gut problems. They may have asthma. They may have irritable bladder. They may have temporomandibular jaw dysfunction, which is where you know, your jaw almost comes out of socket. They may have fatigue, they may have pain, but there are so many things, and this isn't often recognized. And the people who've been really, you know, spearheading hypermobility research were Professor Rodney Graham and Alan Hackham, and they designed a 5-part questionnaire. And if you score 2 or more on these questions, you are probably hypermobile. If you don't, it doesn't mean to say that you're not. So one of them is could you now, or could you ever bend your thumb back to touch your wrist, which is, you know, what I did with this. Could you now, or have you ever been able to bend to put your hands flat on the floor without bending your knees? Can you now, or have you ever had a joint dislocate? No, as a child or teenager, did you ever have a joint dislocate? When you were a child or teenager, did you ever amuse your friends by contorting your body into strange shapes or doing the splits? And then the final question is, do you consider yourself double jointed? And if you answer 2 or more to those questions, then you probably have joint hypermobility.
Yeah.
But the big problem is that's not necessarily a problem. But if it comes along with medical issues, then you probably have a joint hypermobility condition.
Yeah.
And then the
I think
problem
that's an
is,
important part of it, is that like a lot of people, I think part of it is that for most people, it's a case of, this is just the way I've always been, so this is normal, until
yes,
somebody pokes me and says, hey, that's not normal, right? And a lot of this tends to be just part of the way people have just always lived their lives, and they don't really recognize these things because nobody's shouting about it. And
No.
it tends to go on and on and on and on until it gets to the point where actually it is really starting to hurt. It's really starting to cause problems for people.
No, and I think the thing is these things tend to run in families, like autism and ADHD. There's no, most of the time, there's no clear genetic cause. There is sometimes, but there isn't often. And so, you think, well, all my family members can do that. I'm not that unusual, or I'm less bendy or flexible than the rest. And then the other thing is things that often go with hypermobility, like the dizziness on standing or after a hot shower or a bath or a large meal. Some people think, well, isn't that just a completely normal everyday experience? Doesn't everyone feel dizzy when they stand up? And it seems not.
Yeah, and I think a lot of it, and I think the family thing is a big part of all of this. I mean, I can remember as a child, for one, taking both my legs and wrapping them behind my head and walking around on my hands for fun, because this was a fun thing to do, and not thinking anything about it. But also my grandmother, who even up into her 60s and 70s could lie on the floor, take her legs and bring them back over and put them flat on the floor on either side of her head, and all sorts of other contortions. I used to think I was not very bendy, because I could only get my head, my feet, I could only get my feet to the back of my shoulders. I couldn't get them onto the floor. So I thought, well, I'm not bendy. And it's where you're what you get to see as normal or unusual shapes how you actually understand that stuff. Yeah, and if you're surrounded by it all the time, it really doesn't seem to register a lot of the time. But also, I think another thing is, especially with things like different types of neurodivergence, when something like that's kind of going unrecognized, 2 things happen. One is you get diagnosed as autistic or ADHD. That becomes the thing, and it's focused on that. And one, it takes attention away from other things that might be going on, first of all, but also we get that really unfortunate kind of what's called the diagnostic overshadowing, which is a nice phrase which I've found recently, which is so good. I like it. Where you get it's the autism response to everything. Oh, they got gut problems.
Yes.
Well, that's just the autism. Oh, they get pains in their joints, or they've got low muscle strength. Well, that's just the autism. They've got problems with sleeping. Well, that's just the autism. And everything just gets dismissed and dismissed and dismissed and dismissed. And I think trying to get all those bits and pieces back together and getting it all, because it is a complex picture, isn't it? I mean, there was a paper there recently by Carolina which got this lovely diagram in it, which made me just kind of clap my hands in delight, because it just connected up so many different things. And it was just, yes, this is where we need to get to with this, because it's starting to connect together the mental health stuff and all the hypermobility stuff and the EDS stuff and the social interaction stuff and the neurodivergence, and I'm just putting all of these things into one picture together and saying, look. And I think it was, from my point of view, it wasn't a revelation, because I kind of had gotten most of that picture put together anyway. But I've shown it to a few people who kind of went, ooh, and then they looked a bit closer and went, ooh. And you know, when you get that little gap between the oohs, you know, they're kind of like processing like mad. And you can see it all kind of happening. But that's me jumping ahead. So my question is this.
That's okay.
Well, you've got to be enthusiastic. I mean, if we're not going to be enthusiastic, what's the point? I suppose it's easy for me to kind of say that. I've read the stuff, I've thought about the stuff. So from my point of view, I'm kind of skipping ahead, and I need to be conscious of who the audience is. So maybe could you just kind of like pin down, because there have been a whole bunch of papers on this, but spread over like a decade and more than a decade. What are the kind of things that the research that's been done so far? What has it told us? What connections is it making, or what kind of clues is it giving us about the connections that are going on?
Between hypermobility and neurodivergence.
Yeah, and
Or,
also the kind of the mental health stuff as well, because I think that's such a big part of the story for both of them, you know.
So basically, in the hypermobility world, we can be fairly confident now that hypermobile people are more likely to experience anxiety, probably particularly panic. And we know that that's been replicated over and over again in clinical populations, in non-clinical populations using questionnaires. And some of the work that we've been doing in that space, and actually we have a paper kind of under review at the moment about it, brain imaging paper, is that probably the relationship between hypermobility and anxiety is in part due to this difference in the body that leads to the heartbeat rise on standing, the postural tachycardia syndrome. So, you know, we were talking about how hypermobility is a difference in connective tissue, and that connective tissue is everywhere in the body. It's in the vasculature, so the parts of the body associated with the blood vessels. And so if you imagine, when you go from, say, lying to standing, gravity exerts an effect, and your blood has got to get back to the heart. And that is actually quite a tricky process, and is normally dependent. There are no valves in veins to get blood back to the heart. That's dependent on the muscles and the connective tissue exerting pressure to make sure that that blood goes back to the heart. And so you can think, if someone has floppy connective tissue because they're hypermobile, that it's actually harder to get the blood going back to the heart. And obviously the body is designed, the processes, physiology, to make sure that we keep our tissues oxygenated, because that is required for survival. And so the heart does this thing whereby if you aren't getting enough blood coming back to it, your return is poor. In order to maintain blood going out of the heart, it has to raise the heart rate. It's like a maths equation, and that's what it does. So you can see for hypermobile people, they're prone, perhaps because of going from lying to standing, a change in posture, or from a change in temperature that can also lead blood to pool in the peripheries. Also eating, that can cause blood to go where it shouldn't. All of those things are causing all of these changes in heart rate and the balance of the flight, I always say this wrong, flight and fight nervous system, and the rest and digest nervous system. And so you can sort of think, well, if you don't know that, if you as a person, your physiology is seemingly quite random, and you're getting palpitations, and you're feeling lightheaded and dizzy, you're sort of wondering, is something bad going to happen? Am I feeling anxious? You can see how that could lead to feelings of anxiety. And so yeah, we know that, yes, there's a relationship between hypermobility and anxiety. We also know that there's a relationship between, we looked in all the children born in Bristol and Avon in the early 1990s, a birth cohort, and we found that the hypermobile children were more likely to experience common mental health problems like anxiety and depression by the time that they were 18. We know there is some work, we're doing some work at the moment, sort of trying to link hypermobility, neurodivergence, and eating disorder. We're also
very,
looking
very common as well, yeah.
There's not a huge amount of work out there about that. And what we want to look at is, typically work is focused just on autism and anorexia, and we want to look at eating or disordered eating more broadly and neurodivergence more broadly. And then think about, well, if you've got a hypermobile gut, you know, it might be moving in a strange way, you might have postural tachycardia syndrome, you might feel ill after eating, you might have inflammatory stuff, which we know is kind of going along with hypermobility. All of those things could kind of set up, you might have irritable bowel, or what they call irritable bowel, and all of those things could interact with neurodivergence to lead to disordered eating. So we're doing some work in that space. We're doing some work thinking about bipolar disorder, and we just had a really interesting, I think, really interesting paper published in the last couple of weeks, where we looked and we saw that neurodivergent characteristics were associated with difficulties regulating emotions, particularly a construct called dissociation. And that relationship was actually related to something called proprioceptive uncertainty. So like difficulties about where you are in space. And that whole link between neurodivergence and emotion regulation, because of proprioceptive uncertainty, was in fact to do with the presence of hypermobility. So we know that there's this hypermobility and neurodivergence separately are associated with being more likely to experience mental health problems. We know that. And we also know that hypermobility is associated with lots of physical things. And one of the areas that hypermobility led me into was not only the autonomic problems, that's the postural tachycardia syndrome, but was thinking about pain and fatigue. So we've been doing work about fibromyalgia and ME/CFS, and we showed that a lot of those patients have both pain and fatigue. Even if they have fibromyalgia, they often have a lot of fatigue. And if they have ME/CFS, which is fatigue, they often have a lot of pain. And we showed that 4/5 of those were actually had hypermobility conditions, but the vast majority, only 1/5 of those patients knew that they were hypermobile or had ever been told that they were hypermobile. So that is another area, and that also then led into work thinking about long COVID. So we had a paper published earlier this year about you know, those 5 questions that I asked you. A COVID symptom cohort or biobank, 3,000 people answered those questions, and we looked to see whether being hypermobile was associated with long COVID, and it was. You're 30% more likely to experience, not recover from COVID if you were hypermobile. So you can sort of see how all of these things are intersecting. And just this week, we published a paper again in the ALSPAT birth cohort, so all of the children born in Bristol and Avon in the 1990s, that there were about 5,000 of them that were 18. If you had neurodivergent traits or characteristics rather at 7 or 9, so it was autism at 7 and ADHD at 9, you were more likely to experience chronic disabling fatigue at 18. And this was in fact linked, now this is fascinating, linked to your level of circulating inflammation at the age of 9. So something is going on, either hypermobile, well, I mean, we didn't expressly look at hypermobility in that paper, but hypermobility is probably a link there. So maybe there is something going on in neurodivergent people, maybe because of hypermobility, that means that the immune system is working in a different way, hyperactive, autoimmune, something like that. Or maybe being neurodivergent and being a child is leading to stress, you know, physical stress that is then altering the immune system, maybe, you know, difficulties with like teeth problems or gut problems means that you're more likely to become inflamed. So there's so much to try and piece together. But
And
I
I
suppose,
think,
sorry.
yeah, I was going to say, like, from my own perspective, approximately over the same kind of time scale that you've been kind of looking at, you know, the last 15 odd years, so 10, 15 odd years. For me, as the nerd, outsider, amateur, approaching all of this, a lot of the stuff that you've talked about is the kinds of things that I've come to, but coming from the point of view of the kind of neurodivergence, you know, coming at it from the autistic perspective, from the point of view of ADHD, but also things like BPD and CPTSD and all of those kinds of things, and saying, well, you know, what else is in there? And constantly in the background, there's this murmur about hypermobility. Where does the anxiety arise? That kind of thing. And it's almost, when I first kind of started seeing and actually paying attention to this research, suddenly starting to see other people talking about the same things and looking at the same kind of things I was looking at, but coming at it from the physiological side of things, and just seeing this stuff just beautifully kind of mesh in the middle between the two. But one part of the puzzle that I was that I was coming at, in terms of like, how does this entanglement come about? How does it work over the course of somebody's life? Because this is about just human beings being little kids and just having their life, and all of this stuff entangles itself as a part of them living their life, right? So yes, there's things going on in the background, but it's those characteristics of how the stuff mingles together. One, as anyone who's listened to me talking in any training courses or anything like that will be probably know where I'm coming from with this. I'm a big fan of feedback loops, and I think part of what's happening here is, maybe you could have a view on this, is that if you've got a mix of certain kinds of things, and it doesn't have to be the same mix, because I think this is one of the things that confuses the story, is that you ask one person, well, you know, are you hypermobile? No, but I'm very anxious, and I also have this going on and this going on. But that's different to somebody else. They've got a different mix, and somebody else got a different mix, and trying to find what's the common factor. The common factor is certain kinds of things that stress you tend to feed into that feedback loop and build up that stress and the anxiety and the adrenaline rushes and the insomnia and, you know, the joint pains, and all of these things are kind of, yes, some of it is coming from this cause or this cause or this cause, but other things only make it worse. And it's that kind of reinforcing effect, which could come from a whole bunch of different places. So yes, you can be, as I said, like Tourette's and autistic and not bendy at all, but have desperate anxiety and suffer from depression. But somebody else has got a completely different profile, but the actual effects that's having in certain parts of the story are very, very similar. And I said, how did these two people end up with the same experiences coming from these things in the background, which are so different? And I think that mix, as they get mixed up together through your life, and they just reinforce each other. And it doesn't really matter what the dominant thing was originally. If you get enough of these things in a mix together, you're going to end up with a similar kind of outcome, you know.
Yeah, and I think it probably, I don't want to use the word kind of wrongly, but I think it's a calibration sort of sensitivity issue.
I love it when people do this. Calibration, again, is one of the words I keep using. Yes, calibration is.
And I think that you know, sensory processing And obviously, if you think that there's a difference potentially in connective tissue, this is the extracellular matrix. This is everywhere. This is in all the sensory organs.
Yeah.
This is the basis of sensation. It's also, you know, there's a lot of connective tissue in the inflammatory system, which is also going to sensitize things, and the autonomic system, which is going to sensitize things. Is that yeah, people are more sensitive to some of these physiological changes, or they have a system that is more reactive, and trying to regulate that and keep that in the right window before it gets out of the window of kind of tolerance that the system can handle is really the key. But I suppose what I forgot to say, sorry, is that what we have done over the years is we have demonstrated, as have other people, that hypermobility is associated with autism, ADHD, Tourette syndrome. Other people have looked at dyspraxia. And that what a really nice finding that we had was that neurodivergent people are more likely to be hypermobile. We showed that, whereas previous research had shown that hypermobile people were more likely to be neurodivergent. But what we showed is the link between being neurodivergent people were more likely to experience physical health symptoms, particularly pain and musculoskeletal problems, and also the problems with the involuntary nervous system, and that link was mathematically due to hypermobility. So that was a nice kind of coming together,
Yeah,
of things.
yeah. One thing that immediately brings up as a question, though, is, and I think this is when we talk about, especially when we're talking about kind of like, particularly with autistics, because there's been a lot more history and a lot more research and therapy stuff thrown at the idea of being autistic anyway than in most of the others, is when it comes to things like therapy, a lot of the work has been kind of like, well, does the person need speech and language therapy? Do they need occupational therapy? Do they need talk therapy? What kind of things can help the person? The one that always seems to get missed out is physiotherapy. But really, actually, and this is maybe one of the things which is coming out of this, is that maybe, and yes, looking at autistics to start with, but let's expand that outwards and look at other types of neurodivergence as well. Just how much might neurodivergent people actually need to think about and talk to their doctors about whether they actually need physiotherapy as part of what will actually make, because we're all about quality of life. Ultimately, it's about saying, okay, how can we make this person's quality of life better, right? So is physiotherapy something that should be in the mix? And when you start looking at it, you start thinking, wow, we could be looking at sort of 70-80% of neurodivergent people who could actually really benefit from a skilled physiotherapist getting into the story here and giving them pointers and advice around all of that. I mean, I've got this thing in the back here, which is a big help to me. I've got all my elbow braces and my back brace and my knee brace and all the other bits and pieces. That's not unusual. You go to kind of a picnic or a meetup, and lo and behold, half the people turning up of wearing braces, or they're using canes, or they're whatever it might be. That's just part and parcel of what the community's like. Do you think maybe we should be pushing harder in terms of changing that story about what kind of help can people get? Should physiotherapy be part of the story, or at least something that looked at?
I absolutely think you're right, and I think that physiotherapy and movement therapy are probably the key. I mean, in terms of trying to get stabilization and strength. I also think there's something about sensory processing as well. So some occupational therapists specialize in that, but it's not very common. So one of the projects that I would like to get off the ground as a consequence of the proprioception paper and the sensation paper that I was talking about is using sensory strategies and proprioceptive, physical strategies feedback strategies to help neurodivergent people not only regulate emotion or help with emotion regulation, but also with things like pain and fatigue. I think that would be really interesting. And what I would be looking for in trying to sort out that work would be to work with physios and OTs rather than psychiatrists, psychologists, rheumatologists. It would be, I think, what the work I was telling you about, the emotion regulation and proprioception work, it suggests that using the body, and we know this, we did some work about hypermobility and anxiety using interoceptive training, and my colleagues Hugo, he led a study about using interoceptive training for anxiety and autism. We know that thinking about interoception, proprioception, physical space is so important, and we know that medication, people are often sensitive to the side effects of medication, and that psychotherapies and things, that they don't people have problems with motivation. Not all of the they might be depressed, it might be really hard to engage, and not all psychotherapy is adapted for neurodivergent people. So I think opening up using the body as a way of helping with some of these issues is absolutely central.
Yeah. I mean, we could, by definition, we could kind of say, well, I mean, this knocks the idea of the brain, the body as kind of two separate things, which we know absolutely is nonsense. But if anything, what this comes down to is, yeah, the brain stuff and the body stuff. Like, no, I keep doing this, but I mean, it's just as a visual, it makes the point. We're talking about this, and if anything, like a tangled ball of wool, there's no way to disconnect the two. And I think that's really one of the big things that comes out of that, isn't it? You can't. They're all interconnected.
You can't, and that's one of the things. I think I gave a talk last year at a conference called it might have been last year, might have been the year before, called Beyond the Neurotype. I mean, I know that you're called Neuro Pride, and we think about neurodivergence, but what you were talking about earlier about overshadowing. I think the primacy of the word neuro in neurodiversity, neurodivergence, means that we forget that actually probably these conditions are bodily conditions just as much as they are brain conditions. And you only need to see neurodivergent people move or sit to know that these are there's motor issues here.
I've been sitting here clunking my spine the entire time while we've been talking, and I tend to try and not make it too obvious on camera, but yeah.
Just to jump in, I actually, much as I hate that you don't look autistic nonsense, I actually think it's really funny, because if you do know what you're looking at, our body language is very obvious, and mostly because of the high rates of hypermobility. I'm even looking at my hand there, and I'm T-Rex handling my hands and stuff. So I do think it's funny when people say, you don't look autistic. It's like, I actually do, but you don't know what you're looking at. So yeah, I would agree completely. I'm just jumping in because I'm aware of the time and that you are a busy person with other stuff going on. I also think that if it's okay with you, what we might do is share the links to, share links to all your research, but those two papers, that the newer papers that you were talking about, because they are fascinating, and they're doing that thing that MAQQI and both yourself and MAQQI referred to, of linking the brain body thing. They're going, look, this body sensation of proprioception is actually linked to emotional regulation. And I think the childhood paper looking at inflammation and the fatigue later on, I think that's really important, because then we can look at, is there something that can be done for that inflammation when they're 9 to help prevent chronic fatigue at 18. It sounds like, when you actually think about it, it's like, that's terrible that we're just accepting. Oh, well, not that we're just accepting, but that's such a common experience, and yet it isn't causing a, what the hell, this is awful, chronic fatigue at the age of 18. So if it's okay with you, we might share those papers.
Oh yes, and
Yeah.
I should have probably said in my introduction, you know, my X name, Twitter name is bendybrain, and I'm Dr. Bendybrain on Instagram. And there's this thing called Linktree, which is got loads of links. And if you just look up Linktree bendybrain, most of the stuff pops up, including all the publications, but lots of little videos and things. The other thing I did want to say is that you know, this event is for Neuro Pride, and I want to say, you know, for the conversation that we've had, you know, about anxiety, pain, fatigue, could seem a little depressing, possibly. And we have another stream of work which is related, basically looking at neurodivergent and hypermobile strengths. And this is sort of coming together. So we have a student who's about to submit a paper. He did some qualitative work looking at how creativity for neurodivergent people, you know, how important that can be in a number of domains. We're also doing some work looking at the interlinked nature of hypermobility, creativity, and neurodivergence. So, you know, trying to tie these things together. And I think, you know, in neurodivergence, we think about a spiky profile, don't we? That, you know, some people, they have challenges, but they also have strengths. The same thing is true for, you know, like for civilization, you kind of need neurodiverse thinkers in order to, you know, think outside the box and get things done. The hypermobility, yes, it comes with a lot of difficulties, but is also a huge asset at other times. So, you know, there's piano pieces that can only be played by hypermobile fingers. And a lot of sports people who, you know, it's very important.
Who don't know yet, but they'll get there. Yeah, it's that kind of thing. And that, as you said, this is an event for Neuro Pride, and I can't understate how creative our community is. One of the things we'll be sharing on Neuro Pride Day is a video of pieces of art, poetry, photography that people have sent in. Our theme for this year is passion. And like we do, I don't know if you're aware of the concept, I'm assuming that you are, but the concept of lightning talks. So we'll have people coming along and talking about their passions, and we'll have a soapbox session where people will talk about more, let's be honest, more ranty, but that kind of thing, because it is really like, there are ways of being. I have to be honest, even though I would prefer not to sublex, and I would prefer not to have some of the stuff going on, I wouldn't do away with any of it either. Do you know, that kind of way? It is an integral part of me and how I've experienced the world. And I think that's the same for an awful lot of people. And it gives you a perception. It influences your perception of the world. And I think the work that you're doing around emotional regulation and figuring that side of things out can actually help people so much. Because I'm very much a person that the more knowledge you have about yourself, the easier it is to look for support. Like if you have the word for something, it's easier to find the support for that something. And yeah, I think as you both said, I think there needs to be a shift in the way that we try and support neurodivergent people. There needs to be a shift into understanding that people are most likely multiply neurodivergent, and how those things impact on each other, but also a shift in thinking about the brain and the body together, like you said, and talking to people. Holistic, that's the word. I was searching for the word. A holistic approach to this, and not in a kind of trite, buzzwordy kind of way, but an actual, like, you know, when people come into you, I'm an early childhood educator, that's what I do, and people come into me and they're like, oh, they're very sensory. It's like, that means nothing. We need to start seeing people as individuals with their spiky profile and all, and being like, what supports do they need? What things do they not need support with? And that comes down to everything in terms of what I think learning about hypermobility and learning about the impact and the way it affects all aspects of a person's life will make a huge difference in being able to provide that support across the board. It really, that's what I think, like when you were talking about different things about the physiological differences, if you just say, oh, they're just sensory, firstly, doesn't make any sense to me at all. But also, there's physiological reasons why somebody finds the light too bright or the sound's too loud, or do you know what I mean? And if you understand that, it can build empathy in a person who doesn't experience that.
Yes.
Do you know what I mean? Because I think when you were talking about disassociation, I do think that a lot of disassociation happens because of very young neurodivergent people being essentially gaslit about their physiological reactions to things. It's not too loud, it's not too bright, it's not too whatever. And I'm talking about wider society, are actually causing a lot of that disassociation. Do you know what I mean? Some of it is inherent, but a lot of it is not. So I think, yeah. Sorry, that was often a waffle.
No,
but...
well, you're being tipped into a dissociated state when perhaps you didn't need to, because you're having to put up with it or mask it. Yeah, no, absolutely.
Yeah. It's very much a chicken and egg kind of situation, isn't it? It's like there is no way to kind of figure out which came first. And I just want to say the interview was absolutely fascinating. I found it really, really interesting. And I just wanted to say a huge thank you to you both for taking the time to have this discussion. I genuinely think, and I know people always say this at the end of interviews and everything, genuinely could have listened to the two of you talking for another 2 hours. But I am conscious that we're all busy people and you have things to do. But yes, thank you so much. I really do appreciate it. And Neuro Pride, I'm speaking on behalf of Neuro Pride there. We really do appreciate you taking the time. And I would advise anybody to check out your work if they have any interest at all in this area, or even it's just, yeah, it's really, really, and what I like about it, this is going to sound really, but it's very accessible work. Do you know, sometimes you're reading research papers and, you know, you have to kind of go off and Google a load of terms and everything. Your research is actually very accessible and easy to parse for people. So yeah, even so, there might be some people here and they're like, you know, oh, but I'm not into research, I don't know, I won't understand. It actually is. And as you said, a lot of the videos and other bits that you've done break it down either further and make it easier. So if you are a person who's watching and going, oh, but I don't understand research papers, I can't read them, do check out the Linktree, because there's a lot of information there that is done in different ways. So whatever way you take in information, there'll be something there for you to be able to link in with. God, that was a terrible link. Sorry.
With the LinkedIn,
oh,
LinkedIn on the Linktree.
Yeah. My was like, no, that's the only word. Yeah, sorry.
No, and I want to say thank you so much for giving me the opportunity to have this conversation. And I also want to say, you know, I'm standing here telling you about all of this, but the work that we have done is been, you know, part of a team. There's an awful lot of people who have been involved in this, and also lots and lots of people have taken part in our research, and all of the charities and organizations who have funded the research. So we have to say a big thank you to everyone, and particularly to Hugo Critchley and my colleague Lisa Quat.
Fantastic. Thank you very much.